Welcome to Senadhipan Education Foundation. I'll just go through the history of Senadhipan Education Foundation. Actually, it was launched in 2012, Jan 30th by, it was launched by none other than Seon Han Kim, our colorectal surgeon from Korea, by releasing a set of CDs, educational DVDs. And then he visited our hospital in Holy Cross Hospital, Kottayam. It was not active till 2020 July, till the COVID came. And recently in July, Dr. Padalivelu inaugurated or released our logo. And he released the logos, and it's an online platform. We are live streaming live surgeries, streaming live lectures with the eminent faculties. We are planning to do certificate courses also in the future. We have got global acceptance. You can see the meeting participants. Last time meeting, 889 Zoom participants were there, of which 714 was from India, and rest of the participants were from rest of the world. So today we are having a webinar on risk reduction strategies in laparoscopic inguinal hernia repair. We all call Dr. Bhatia as Global Bhatia, not only because he is known globally, but also because he runs an institute called Global Hospital, and he is the head of the Global Hospital. He is fun-loving, he is adventure-loving, he is a perfect laparoscopy surgeon and a robotic surgeon. You can see his pictures here. He is a seasoned speaker, adventure-loving, wildlife photography, storyteller, motivational speaker, and robotic bariatric surgeon. And also we have a very good moderator here, Dr. Ovi Sudhir. He is my friend. We traveled together to many places. You can see one of the places we went to Korea. It's in Samsung Hospital, which you are seeing there. He leads a very good family life. More than that, he is also a fun-loving person. He is one of the pioneers in lab surgery in India. Actually, he taught my professors when he was in Trivandrum Medical College in laparoscopy surgery, when laparoscopy was just coming in. He contributed immensely to TA Forum to India, and he has got a lot of teaching assignments in many parts of the world. We are talking about one port. He will be showing that procedure now. Over to Dr. Sudhir, please.
Hi, Baiju. Hi, everybody. Thank you. Thank you for the nice words, Baiju. It's good evening, and welcome for the another show in Senadhipan Education Foundation, another academic show. Now, the hernia surgery, laparoscopic hernia surgery is a fascination of, I would say, every young surgeon. If you know the plane well, if you can dissect the plane well, and if you know the mesh placement well, it's not a very difficult, but people say that it has a very steep learning curve to get it to be a master, to get a master in hernia surgery. And I would say that actually I get a kick, like even if I don't do, if I do a gastrectomy laparoscopic, I get a better kick while doing a good laparoscopic hernia repair. Because it's a really fascinating study. And, for today's discussion, we have none other than one of the pioneers in hernia surgery in India, Dr. Parveen Bhatia. He has contributed immensely to hernia surgery. He is one of the early person to write a book on hernia operations. And you might have heard him many times in many forums, but here the advantage is that he is going to speak for more than 1 hour, or whenever you want to, you can clarify all the doubts from his mouth directly, because there is no time limit here. So Dr. Bhatia will be speaking to us on complications of inguinal hernia repair. So over to Dr. Parveen Bhatia.
Thank you, Dr. Beju, and thank you, Dr. Sudhir. I think rather than speaking on the topic of laparoscopic hernia repair, we could have talked about how to do the parachute skydiving also. And many times, can you imagine, Beju, when I have done skydiving 3 times, anytime and every time, all people ask that, is there any risk? And I say, no, it is not at all a risky thing, because the pillion rider is there and you will have a safe landing. Only thing is that you have to enjoy when you are in the air. Now today, before the start, I would say that it is not the wound that teaches, but the healing. I think this is very, very important, that we as surgeons, we should carry on learning that how many mistakes we make and how many times we are interested in learning from our mistakes or other mistakes, so that ultimately the beneficiary is the patient. And today I bring greetings from Institute of Minimal Access, Metabolic and Bariatric Surgery and Institute of Robotic Surgery, Sir Gangaram Hospital. And as Dr. Beju introduced, from our own hospital called Bhatia Global Hospital and Endosurgery Institute. The topic which has been given is risk reduction strategies in laparoscopic inguinal hernia repair. What I plan to do is that we will have a presentation for approximately 1 hour, and then we would love to have as many questions as possible. And as Dr. Beju was also telling, people can note down the question and put it on the chat box, or they will be unmuted and they can ask the questions directly, so that all of us are learners and we will carry on learning. Meantime, I have requested Dr. Sudhir also to share his 1-port laparoscopic hernia video, so that all of us are learning. Now, many times when we take the flight, then we are never ever questioning that who is the pilot today, how safe is the flight. But all of us know that there is a risk, and if we take the flights, then the challenges can occur. Similarly, I would say that in laparoscopic inguinal hernia repair also, it is a different kind of anatomy that one knows about it. We have been taught in our undergraduate days the anatomy from skin, subcutaneous tissue, from outside in. But in laparoscopic hernia repair, we have to unlearn, learn, and relearn the anatomy. So the outline which I am going to have today in my presentation would be that know thy anatomy well. Then we will be spending some time about critical view of safety or critical view of myopectineal orifice. What is the risk pre-operatively, per-operatively, and post-operatively? And then we will be sharing few experiences about the recurrences, seroma, surgical site infections, mesh explantations, and neuralgia, and so on and so forth. As we discussed, that we have to unlearn and then relearn the anatomy. This is one of my favorite slides, which I have been sharing in all the conferences all over the world, that this inguinal region, for example, right inguinal region can be divided into 2 by the iliopubic tract, the superior aspect and the posterior aspect. The superiorly, again, the inferior epigastric veins, two veins and one artery, they divide the area into a direct defect, and lateral to the inferior epigastric is the indirect defect. But most important aspect is the level below the iliopubic tract. All of us know that we have to be absolutely systematic when we are operating. Means that we should go, even if we are doing TEP, totally extraperitoneal hernia repair, or TAPP, we should start our dissection from midline and then start gradually going lateral. In the sense that this is the pubic ramus and the pubic bone with the Cooper's ligament attached to it. And then this is the cave of Retzius that one has to be very, very careful. As we move laterally, this will be the triangle of doom or angle of doom formed by vas deferens medially and testicular vessels formed laterally. And we have to convert the angle of doom into a triangle of doom by taking the peritoneum in a horizontal fashion. I will share the videos later on. And as we move laterally, then we see the area or the area of pain. And if we combine this triangle of pain and the triangle of doom, this is called as trapezoid of disasters. So what I mean to say, we have to prevent the complications right from word go in laparoscopic hernia repair. And as Neil Bohr, the physicist, had beautifully written that an expert is a person who has found out by his own painful experience of all the mistakes that one can make in a narrow field. And TEP or TAPP is such a field that if we are not knowing our anatomy well, then we can have a lot of challenges later on. And I must give a lot of credit to Jorge Dias and Edward Felix for giving this critical view of the myopectineal orifice in annals of surgery. And they have divided the steps of TEP or TAPP into 10 or 9 steps. But again, I would not go into the details of these steps, but I would put it this way, that one has to be very, very careful in doing the dissection in this critical view of safety. For example, when we are dissecting in the TEP or TAPP, then we have to go beyond the midline. If we go beyond the midline, then the chances of medial most recurrences are reduced to nil. 1. And as we go into the cave of Retzius, then we should make sure that we dissect by around 2 centimeters, so that ultimately the mesh which we are going to place between the pubic bone and the urinary bladder, which has been emptied, will be lying flat. If we have not made this space, then as the bladder would distend, it can cause the curling up of the inferior margin of the mesh, and that can lead on to medial most recurrences also. 1. Then second, more important aspect is that all this area of direct defect, that means the Hasselbalch triangle, the fat should be taken off. It should be dissected, so that ultimately, again, the medial most recurrence is the commonest after laparoscopic surgery, even after the open surgery. So one has to spend some time here on the medial aspect, which is medial to the inferior epigastric vessels. And as we march laterally towards the Cooper's ligament, then we should never ever rub onto the Cooper's ligament because of these ricotusial veins of Bendavit. If we cause an injury onto the corona mortis blood vessels, which are anastomoting between the external iliac and internal iliac vessels, and that can lead to lot of bleeding. And we always feel that if the bleeding occurs, it can be so bad that the surgeon starts thinking, why was he born? And then as we move laterally, one has to make sure that once the direct defect has been taken care of, the indirect sac should be definitely separated off the vas and the testicular vessels. But please, for God's sake, do not touch, do not skeletonize the vas and the vessels. One should peritalize the vas and the vessels, and this peritoneal sac should be, this one should remain close to single cell thick peritoneum. The whole of the game of TEP or TAPP is, it is totally extra peritoneal, not extra fascia transversalis. So extra peritoneal, one should remain close to single cell thick layer. Follow the white. I know Dr. Jignesh and we have been pushing this, that whenever we do the laparoscopic hernia repair, follow the white. That means the Cooper's ligament. Then as we start going laterally, we should see this sac. Vas has been seen, that is again white. The peritoneum is appearing to be a white line structure. Follow the white. Please make sure that I will show you in the videos also, the fat which is present laterally, or the fascia transversalis bilaminar layers, they should go towards the abdominal wall. Fat belongs to anterior abdominal wall. One has to remain close to the peritoneum when we are dissecting. And if we are making such a space that we make sure that the peritoneum has been taken down and it has formed the horizontal limb of the triangle of doom, the lipoma of the cord will be present lateral to the testicular vessels. That has to be taken care of if we want to prevent the pseudo recurrence. And as we move laterally, then one has to be safeguarding all the nerves, and that can lead on to definitely a good recovery to the patient. Initially, as Dr. Sudhir was also mentioning, we were doing the TEP or TAPP. I am very, very clear in telling that one should not be only TEP man or only TAPP man. One should know the indications of TEP and TAPP. But now lately, in last few years, after the advent of abdominal wall reconstructive surgery, now we are doing all kind of hernias by E-TEP method. That means enhanced view or extended view. And in this, we make an incision quite high up into the left side of the anterior abdominal wall. And with the help of two ports, the 5mm ports, definitely we go on remaining close to the white, follow the white. In this situation, you would appreciate that though we are having the harmonic scalpel in our hand, but we are not using it. What I mean to say, that we should not fulgurate the tissue whatsoever comes on our way. If we are in a right plane, this is a pseudo sac, again follow the white. So pseudo sac, if we are remaining close to the pseudo sac, then it can go, and we have already been able to see the direct defect. After seeing the direct defect, then we go laterally and we are able to again follow the white. The vas deferens will be here. This is the peritoneum. We should not touch or hold or skeletonize the vas and the vessels, but remain close to the peritoneum. If we are remaining close to the peritoneum, we will not have much of bleeding, not much of this energy source will be used, and we will be able to do the dissection. Now, after doing the dissection completely, again and again, we are able to appreciate the peritoneum. The peritoneum is taken care of. And again, when we are doing the dissection, again, when we will discuss about the recurrences, I will definitely love to tell you that the inferior margin of the mesh, this is the inferior margin of the mesh, should rest absolutely comfortable close to the peritoneum. If, for example, there is a rolling up of the mesh or the peritoneum goes underneath the mesh, then the chances of recurrence are very high. When we are doing TEP, one can lay down the mesh, unroll the mesh on the floor, or when we are doing, for example, E-TEP, then because of so much of extended, enhanced space, one can roll it up onto the anterior abdominal wall, again making sure that when we are putting the meshes, then the midline, on the midline, both meshes should be overlapping each other. Because again and again, I am repeating the same thing, that it is the medial most recurrence which is commonest. So we should be very, very careful. And when we have fixed the mesh of 15 by 12 centimeters at least in these spaces on each side, and then we deflate the extra peritoneal space, it is a good habit to check by inflating the space again, and then we will be able to see that yes, a mesh has been resting absolutely comfortable. And in this kind of small video clipping, we are just showing the importance of single cell thick layer of peritoneum. Means again and again, the fat belongs to the anterior abdominal wall. We should remain close to the single cell thick peritoneum, carry on reaching up to the medial umbilical ligament, and then once we dissect, we have to be very, very careful that we do not injure the inferior epigastric vessels. The inferior epigastric vessels should remain clad in the two lamina of fascia transversalis. This fat belongs to the anterior abdominal wall. When we are going and doing the dissection laterally, I would not love to disturb these nerves, the lateral femoral cutaneous nerve of thigh, genitofemoral nerve. One can appreciate it is dividing into two, the genital branch, one can see the psoas, but again it should remain clad with the loose fibroalveolar tissue. We should remain close to the peritoneum, and this is an important step that one should be able to go and dissect up to the mid belly of the psoas. And when we go medially, then also we should make sure that we are remaining close to the peritoneum, and then we are interested in seeing the pseudosac. This is the pseudosac one could appreciate, and then we go behind the pubic ramus, pubic bone, so that once the dissection is done, and that too in such a manner that we will be able to place the 2 centimeters of the mesh behind this in the pubic arch, pubic ramus, and we should not injure the bladder. The mesh should remain flat when we are doing the dissection. If the mesh is having curls and curls, then definitely the chances of recurrences are increased. So this kind of dissection has to be there, and I would base my whole of my presentation on the few guidelines of international guidelines for groin hernia management, and this is the hernia surge group which had given. And in this, what they have done is, and this is a for younger colleagues I am saying, it is a beautiful publication of current concepts of inguinal hernia repair. And in this, the hernia surge group, what they have done is that they have taken the representatives from all the hernia societies, maybe European, American, and Asia Pacific, and Afro Medical, and Middle, and so on and so forth, so that ultimately the experts have contributed, and they have found the risk and risk reduction strategies of tackling the laparoscopic hernia repair. Now, for example, as we discussed that pre-operatively, one should always know that lifetime risk to develop an inguinal hernia is of the order of 27 to 43% in men, and it is obviously uncommon. Femoral hernia is more common in women and of the order of 3 to 6%. And once the laparoscopic hernia repair is done, or the primary inguinal hernia repair has been done, still, in spite of the advancement of the technology, advancement of the technique, still 11% of all patients have a recurrence, and that is too high a number still. And then 10 to 12% develop chronic pain, and out of these 12% patients, 1 to 3% of the patients have severe chronic pain. Can you imagine? We have witnessed the pain in such kind of, I would say, cripples. These become cripples when they come after getting the surgery done elsewhere, and some tack has been applied on the nerve, and even the obturator nerve has not been spared. The lateral femoral cutaneous nerve of thigh has not been spared, and the patients have severe excruciating pain. And again, the risk which is there for strangulation, many times all of us have seen the publication on watchful waiting versus the active surgery. So there are the school of thought, and Felix was also one of them. He had presented a beautiful publication, but those watchful waiting patients also have a risk of developing the strangulation later on in life, and that can lead to challenges. So these watchful waiting patients also should be followed up regularly so that they do not land in emergency surgeries. And again, the incidence is of the order of 27%, as I mentioned, in males. And one should know that indirect inguinal hernia is more common in males as compared to females. Now, again, it all depends on the choice of the expertise of the surgeon. For example, now if the patient is having recurrent hernia, definitely if the surgeon is very well knowing about the anatomy and he has been doing laparoscopic hernia repair, is the gold standard. Similarly, if the bilateral hernia is there, again laparoscopic hernia repair. But in the primary hernias, if the surgeon is well trained, nothing like laparoscopy, but I would not discard the open surgeons also. But I would love to discard those surgeries, not surgeons, those surgeons who are not using the mesh. For example, mesh is a must today for the elective surgeries of inguinal hernia repair, whether it is primary, bilateral, unilateral, and recurrent. And if the patient has presented in emergency, for example, if the incarceration is there or strangulation is there, or if it is a large inguinoscrotal hernia more than 3 centimeters, definitely the surgeon has a choice whether he wants to go in for laparoscopy or he wants to go in for open. But again, there should be, I would say, one should maintain that integrity, that there is a thin line between ethical and unethical practice. If, for example, the strangulation is there, I would just do the diagnostic laparoscopy, find out that yes, there is a strangulation, and then we'll convert and complete the anatomical repair rather than putting in a mesh. And then tell the patient clearly that at this moment, I have not been able to place in a mesh. Maybe later on, if you develop the hernia, we will place in a mesh because of the strangulation, because of the toxic fluid which was there. There will be some situations, for example, in which the previous surgery has been done and groin surgeries or the prostate, radical prostatectomies or hysterectomies have been done. Again, depending on the experience of the surgeon and the patient's preferences, also one should take a decision that whether one will be more comfortable in offering the laparoscopic surgery or the open surgery. A piece of, I would say, caution in selecting these patients is that one should have a low threshold of getting the CT scans. Many times, most of the surgeons, they rely on, yes, definitely one should rely on the clinical sense, but they start relying on ultrasound. but I think the ultrasound does not diagnose the hernias well. One should have a low threshold, especially for recurrent hernias. One should get the CT scan, and in this it has been seen that the positive predictive value of hernias when we get the CT scan is of the order of 97%, and 13% is the negative predictive value. So in such kind of complicated hernias or the incisional hernias or recurrent hernias, definitely we should get the CT scan. And especially when the hernia accidents, this is a beautiful terminology which is being used in the literature, is hernia accidents. That means either the incarceration or the strangulation is there. So if we get the CT scan, one can appreciate that yes, it is not the omentum which is in the hernial sac, but it is the intestine. And definitely whether one will go in with the diagnostic laparoscopy or not, that kind of decision should be made. So in nutshell, I always say that CT scan should be used as a GPS, that we should go to the patient with the GPS on, so that we know that what are we going to perform. Now again, depending on the whether the patient is having symptomatic hernia, if it is an elective surgery, I would not go into these primary and bilateral surgeries. But again, if the recurrent hernias are there, and if the recurrence has been after the previous open surgery, then definitely one should go in and change the battlefield. Means one should not attack from the same place again and again and think that we are going to win. So if the anterior repair had been done previously and the recurrence has occurred, definitely one should now go in for posterior repair, and whether one does TEP or TAPP, it all depends on the experience. But if the previous posterior repair has been done, that means TEP or TAPP, then comes the level of expertise of the surgeon. That if one is comfortable, then one can go in and do the open repair, and that too Lichtenstein repair. But if one has done good number of surgeries, I will tell later on about the surgeon's volume and the hernia center's volume later on. But definitely if one is well experienced, then one can go in for posterior repair. For example, if the recurrence has been there post TEP and one goes in, then one can go in with TAPP and do the hernia repair. Now in this small video clipping, one can appreciate, this was just 3 days back that I had tackled this patient, and he had come with the obstruction on the left side. And when we had got the CT scan also done, but CT scan also showed that there is an obstruction on the left side, and that is the reason that we went in for diagnostic laparoscopy by TAPP method. But can you appreciate the hernia on the contralateral side also? In approximately 28% of the patients, the contralateral hernia is there. And if such kind of situation is there, it was not a strangulation, it was not a basically the toxic fluid was not there, and in that kind of situation we were able to dissect on both the sides, left side as well as the right side, and we were able to place in a mesh. Again, as I showed one of the video clippings before also, that now we are changing our practice from TEP to E-TEP, and that means TAPP, TEP and E-TEP, we have been doing. And again, we always use this OptiView port so that eyes don't lie. That means I have seen surgeons doing the finger dissection or the dissection with the help of retractors, that we go in this retrorectus space, and then if the bleeding starts, it can be challenging. So our thinking is that if one is very, very cautious and one knows about the anatomy. Now you can appreciate that this is the fascia transversalis, anterior lamina, and this is the posterior lamina of the fascia transversalis. One can place the secondary ports in the midline and then carry on remaining close to the peritoneum, follow the white, and then carry on dissecting. What I mean to say, this is just like breaststroke in swimming. Means there is no point in fulgurating the tissues, remain close to the single cell thick peritoneum. If now you can appreciate that we are trying our best that the whole of this fat belongs to the anterior abdominal wall, and we are remaining close to the peritoneum. We should not handle the vas and the vessels, but just doing the blunt and dissection away so that we are able to take care of the indirect sac also. And I would spend some time on that how to reduce the chances of seroma formation after the direct hernia as well as indirect hernia dissection, sac dissection. But here one can see that we are taking the point that we are just using the harmonic for not leaving the distal sac with bleeding. If you leave the blood inside the distal open sac, then the chances of seroma formation are definitely increased. And in this situation, again and again, I would love your attention on this horizontal line of the peritoneum. This vas deferens and the testicular vessels have been taken care of. Then lipoma of the cord should also be either excised or dissected. If we leave the lipoma behind, then the chances of pseudo recurrence are very high. So this kind of dissection, and again laterally it should go up to 2 centimeters anterior superior to anterior superior iliac spine. And when we are laying down the mesh, please make sure that 2 centimeters have gone in the space between the pubic ramus and the bladder. The inferior margin of the mesh is resting absolutely comfortable. The marsupial has been created. And now in this case, for example, we are showing that the mesh can be laid onto the floor as we do in TEP. But again, make sure that we are not leaving the curls and curves of the mesh, and that can lead on to rolling. And then do the desufflation and re-insufflation so that we know that the mesh is nicely placed, and on the operation table only, we are absolutely sure that we have not taken any chance and we are going to succeed, and it is not going to lead on to any recurrence. Now, we will be discussing about the recurrences. Can you imagine that this is the patient who had got the TEP done elsewhere, and as you know that all the challenges, all the recurrences, all the complications, the primary surgeon always says that it has been done elsewhere. He would never ever own any of his hernias which will have the recurrence. For example, now this one can appreciate the mesh which has been placed. And again, if the mesh placement has not been right, then in this situation, even bilateral hernia recurrences was there, and the surgeon had done the bilateral TEP. And in this situation, definitely I would love to go not by open method, but by the laparoscopic method and by laparoscopic TAPP method rather than TEP. And when we go in with TAPP, we find that there are adhesions. Definitely adhesions are there. Now, one has to be very, very careful in deciding about the plane. For example, in this kind of situation, when the dissection is being done, then one should be very careful that we take the mesh down with the peritoneum, because the peritoneum may be very badly adherent to the previous mesh. We should never start
କେତେ ଲୋକ ଦେଖୁଛନ୍ତି?
we should never expand the previous mesh, and then we will be sure that we placed two meshes in this situation, and the size of the mesh should also be such that it is covering, and the patient is not going to have recurrences later on. So make sure that we do TAPP and bilateral dissection is done. Many times I would use a word of caution that people have been able to injure the inferior epigastric vessels, or people have been able to even injure the external iliac vessels, veins. So one has to be very, very careful in taking these kind of challenging situations, challenging cases, because of the previous mesh. Now in this situation, another patient, one can appreciate that the mesh has been placed, but the inferior margin of the mesh was not placed properly, and that is the reason that the peritoneum had gone in, and it has led on to hernia recurrence, and it is a direct kind of recurrence which is seen. And in this situation also, definitely it will be bloodier than the normal anatomy patient, but we should be very, very careful that when we do the dissection, I would give a small practical tip that harmonic is a good instrument to cut the previous placed mesh. For example, if we are finding lot of difficulty in separating it from the vital structures, one can leave a small portion of postage hernia mesh onto these vessels stuck on, and this is absolutely a fantastic instrument if one is using the harmonic rather than scissors or monopolar or bipolar. But make sure that if whole of the mesh is covered by the peritoneum, either by suturing or by the stapling. And I must thank Dr. Anil Sharma for this publication, that surgical repair in recurrent inguinal hernia, the incidence of recurrence after tissue repair, again and again, I am emphasizing that today in 2020, there is no role of tissue repair, in the sense that the recurrence rate is of the order of 10 to 30%. And if one has to go in for some situation that one has to do the tissue repair or the sutured repair, then the shoulders is the only repair which has a recurrence of the order of 0.2 to 4.8. And the Lichtenstein, if the mesh has to be placed, it is having the similar kind of recurrences after Lichtenstein, TEP or TAPP. In the long studies, and so many studies have come and they have compared. I think now the message which I want to share with all our younger colleagues is that there should not be any fight between TEP surgeon and TAPP surgeon, which was absolutely superfluous. Our thinking is that any surgery, whether you are doing an open surgery by Lichtenstein method, or you are doing TEP, or you are doing TAPP, please justify your role and do your best, give your all, so that the chances of recurrence are reduced to maybe nil rather than going up and up. Now, the risk factors for recurrences can be patient-specific risk factors and surgeon-specific risk factors. And again, I have been using these one-liners, as Dr. Jignesh had also pointed out, that surgeon is the most important prognostic factor. Again, if we do the surgery, especially the laparoscopic hernia repair, and if surgeon is not well versed with the anatomy, the chances of recurrence are very, very high. I know that these factors, the patient-specific risk factors, we will not be able to modify them much. For example, even if we tell the patients to stop smoking, they would not. Even if we tell them to reduce the weight, they will not be able, or control the diabetes, vascular disease, connective tissue disorders, and so on and so forth. So these definitely one has to strategize, that one has to optimize these patients and then take up for the surgery rather than just going in for the surgery. But again, the surgeon specific risk factors are, for example, I would again highlight this number, and it is too high a number, that proportion of recurrent inguinal hernia is of the order of 12 to 13% still. Even if so much of development has occurred, so many years have occurred. I started doing the laparoscopic hernia repair way back in 94, 95 after learning from Barry McKernan, the TP, but still in so many years, we are still finding the recurrences, and 40% of the recurrences are present in first 5 years. But 60%, mind you, 60% of the recurrences can present later on also after 5 years. So one should definitely have a good follow-up. And recurrence rates, as I mentioned, after all the three, that means Lichtenstein, TEP and TAPP, it has not been statistically different. And again, there is a question of whether one should use the heavyweight mesh or lightweight mesh. But again, it has been reported in this publication by Cockerling, beautifully done, and they have also based it on the different guidelines, and they have found out that there is not statistically different. But again, a piece of caution is that we had used the lightweight meshes. We found that definitely, for example, Vipro 2 or Vipro Plus mesh was used, and the recurrence rate was definitely higher. So we place the polypropylene heavyweight mesh in all our inguinal hernia repairs so that the chances of recurrences are reduced to minimum. Now again, the risk reduction strategy for managing the indirect sac is that, for example, if, as we showed the video clipping also, one can do the indirect sac cutting, and the distal sac goes to the scrotum and the proximal sac is ligated. But again, in that kind of situation, the chances of seroma formation are definitely higher. And we strongly do and believe on something called as sacoscopy, that as we go in with the diagnostic laparoscopy and we are going to start the dissection, we place the scope within the sac from intra-abdominal, and then we are able to assess whether this sac is going up to the scrotum or if it is just a small sac, and then we will be able to dissect it in totally, or we will have to cut it and leave the distal portion behind. And if, for example, if we are dealing with a direct sac, then the chances of seroma formation are definitely higher if we do not fix it with the Cooper's ligament. So we always make sure that we fix it with the help of tacker on the direct sac, and then the chances of seroma formation are reduced. Now, the size of the mesh, if, for example, the mesh size according to literature is at least 15 by 10, but we have never ever placed size of 15 by 12 below that. We have always been placing higher size mesh, maybe 15 by 15 or 17 by 12 and so on and so forth, but never less than 15 by 12. But literature says 15 by 10 is good enough. But again, if there is a large defect and more than 4 centimeter direct defect or more than 4 centimeter indirect defect, even larger size meshes of the order of 17 by 12 should be used so that the chances of recurrences are reduced. And whether one should fix the mesh or not, again, the surgeon specific. We always believe on fixating the mesh to the Cooper's ligament, whether we are doing TAPP or TEP. But the world guidelines for groin hernia treatment says that non-fixation of the mesh in TAPP is only up to defects of 3 centimeters. Means if the defect size is less than 3 centimeters, one can try not to fix the mesh. But if the defect is more than 3 centimeters, one should always fix the mesh. Again, just showing the photographs of the patients in which one can see the mesh has been placed, but the recurrences are there. And you can appreciate the mesh is there, But medial, this is the medial most recurrence, this is the medial most recurrence, this is the medial most recurrence. So thinking is that when we are doing the dissection, please make it a point that we are having a good overlap of the meshes on the medial aspect. Then only we will be able to justify that the patient is not going to have recurrences of medial side. And again, as I mentioned, there will be some situations in which we will be able to go between the mesh and the peritoneum, but there will be many situations in which we will be not been able to dissect in between the mesh, and then one has to go and incise the sheath also, so and we are able to see the muscle, and then we place in a mesh. Again and again, lesson from these recurrences are that there will be some situations in which we will not be able to dissect completely, and then we'll be able to place in a proline mesh. In such a situation, for example, I purposefully wanted to show this, that this is a TAPE. That means one has placed in a proceed mesh because we were not able to dissect thoroughly. And then we do, for example, as we would do the ventral hernia repair as well as the laparoscopic inguinal hernia repair. In this situation, the mesh obviously is partially covered by the peritoneum, and most of the mesh is exposed, but one should never leave the proline mesh exposed unnecessarily because it can lead on to infection later on. And again, the surgical risk factors are, for example, if the patient is having sliding inguinal hernia, then they have a higher cumulative reoperative rate for recurrence, for example, of the order of 6% versus 4.2% in non-sliding inguinal hernias. So one should again surgeon should be a cerebral laborer rather than a manual labor. If one is finding a sliding inguinal hernia, preoperatively, peroperatively, I would definitely go in for TAPP rather than TEP. And then in TAPP also, one should be very, very careful that we do not injure the sigmoid colon or all those structures. And again, all the lipoma should be reduced and excised most of the times. The surgeons, even if they are doing high volume surgeries, if they leave the lipoma behind, the chances of pseudo recurrence are very, very high. And I, honestly speaking, I am afraid of those surgeons who call or label themselves as fast surgeons. And I definitely was happy to read this statement from this Swedish hernia register, that relative risk of reoperation for recurrence of all operations, all patients operated in less than 36 minutes was 26% higher than that of all patients with an operative time of more than 66 minutes. Means if we try and if we are doing these kind of challenging hernia recurrent cases, and if we start proving to our younger colleagues and especially to our anesthetists that we are fast surgeons and not the safe surgeons, we are going to finish off the surgery in 36 minutes, but we will have a higher recurrence rate. So in Gangaram Hospital as well as in Bhatia Global Hospital, I always tell my younger colleagues that operate with compass and not clock in mind, not the calendar also, but definitely operate with the right direction. And again, they have the Swedish hernia register have given a high center volume recurrence rates also. For example, in those centers in which only 50 procedures are done per year, the reoperation rate is of the order of 9.97% vis-a-vis in which higher numbers are done of the order of 6%. Similarly, the surgeon volume also. It is not the high volume centers which are important. It is the surgeon volume center also which is important. If one is doing the TEP and if is learning the TEP, it is said that yes, first 50 cases one will be able to grasp the anatomy. but definitely one should assist good number of surgeries to his senior colleague so that he is able to grasp the nuances of the TEP, and then only one will be able to prevent these recurrences. Again and again, I am not going to repeat, but I am trying to emphasize this aspect that these meshes have been placed. Good number of cases come to us in which it is a recurrent hernias, and then one has to tackle those situations by doing the TAPP, and we are able to do it. But again, these are challenging situations. One has to be very, very careful with the instrumentation, and definitely one should be trying one's best not to injure the vas, not to injure the testicular vessels, and ultimately, if, for example, in this kind of situation, when the previous mesh has been placed, and if you are working very close to the vas and the vessels, and if you cause an injury to the testicular vessels, the testicular atrophy can also occur later on. But again, the thinking is that when we are going to dissect, then we should make sure that this is the opportunity that patient is not going to come to us again and again for hernia repair. One should do the justice and repair and place in a larger size mesh, and then rest assured. And then in the last few slides are of showing the complications. For example, risk reduction strategies for seroma formation. In this situation, as I mentioned, that there will be situation in which we will be able to reduce the seroma by tacking the peritoneum onto the Cooper ligament in the direct effect, and in the indirect effect, definitely we leave the sac behind or we dissect the complete sac out, then the chances of seroma formation are reduced. But still, the incidence of seroma after the TEP or TAPP is of the order of ranges 0.5 to 15%. And when the patient comes to us with a large inguinoscrotal hernia, we always tell them point blank, right at the pre-operative counseling, that this is going to take its own time. Please do not think that the hernia has recurred, because you have waited for so long for the hernia surgery. Because it is such a large inguinoscrotal hernia, it is going to take its own time. And most of the times, we always tell in the post-op period, when they develop the seroma, then we tell them that it is going to take 3 weeks. After 3 weeks, again they come, yes, slight decrease in size is there, but still it is persisting. We say another 3 weeks, and so on and so forth. And we have realized that most of the seromas are having the reduction after around 2.4 months. But again, the thinking is that prevention is better than cure. If we are able to do the complete excision of the indirect sac, or if we are able to transect and left it open, the distal most, and again a beautiful concept which I had read in the journal, but I have not been able to practice this, is fixing to the posterior abdominal wall. This is a beautiful publication in which they have presented from China, from Dr. Lee and et al., that prevention of seroma formation after laparoscopic inguinal indirect sac. And you can see that they have dissected the vas and the testicular vessels. The distal sac has been dissected, but it is being sutured to the posterior abdominal wall laterally onto the iliopubic tract, so that this distal sac remains open, wide open, rather than remain closed. If, for example, if it gets closed because of the use of the harmonic ACE, then the chances of seroma formation will be higher, and the chances of pseudo hydrocele will be higher. So this is a good concept. It appears to be a good concept that one can take the posterior margin of the sac and fix it to the lateral wall, lateral to the inferior epigastric vessels, and that can lead on to definitely less chances of seroma. But again and again, I must emphasize that time is the best healer. And this is the patient who had presented to us. He is a chartered accountant. But can you imagine that he had got the TEP done elsewhere, and then he had the seroma formation, and he came to us with the CT scan, and I was honestly surprised to see this patient that he had taken the same CT scan. I will show you the CT scan, the same CT scan to the same surgeon, and they had advocated the seroma aspiration. The seroma aspiration was done, and after the seroma aspiration, the patient was also started on anti-tubercular treatment, which according to us is big no until and unless we prove it beyond doubt that we are dealing with mycobacterium or we are dealing with atypical mycobacterium or not. And then when he came to us and he ran away, when I told him that once you have the seroma of this kind bilaterally, then mesh explantation has to be done. You should not have got the aspiration. You should not have gotten the repeated aspiration done. But he vanished for 6 months, and later on he came back to us when he had developed an abscess, and somebody had even done the incision and drainage, and from that incision and drainage, not explanting the mesh, the pus was coming out, and he was using this ileostomy bag every day when he was going to the office. And this is the level of the discharge. So I want to give this message loud and clear that please do not aspirate the seromas. The seromas will be converted into an abscess, and that can lead on to discharging sinus, and that can be challenging. And we have a low threshold of doing the diagnostic laparoscopy in such kind of situations, because we believe and strongly believe that diagnostic laparoscopy does not kill anyone, but lack of it can. Means that we did the diagnostic laparoscopy, we found out that the intestines were not involved in the discharging sinus. There were some omental adhesions. We tried to go into the space by dissecting the peritoneum. We are doing the sacoscopy in this situation. Can you appreciate that? And then we took a decision, because there were a lot of adhesions onto the rectum. Then we took a decision and we pushed in the dye from outside and converted it, and then ultimately we could take the complete mesh out. The risk reduction strategy for these kind of seromas is, please do not aspirate. Even if you have to aspirate, then you have to take the patient into the operation theater, and then in the sterile kind of situation, you should aspirate. And then if it has been converted into an abscess, please carry on harping. Even if you lose the patient to some other surgeon, please carry on harping that this mesh has to come out. This mesh has to be explanted. There is, to my mind, I will show you this some literature support also about there's no point in salvaging the mesh. We should make sure that we get the X-ray done pre-operatively so that we count the number of tacks which have been used, and then we should make sure that we explant 1 or 2 meshes, all the tacks, all the sutures also. Then only and we do the culture sensitivity, and then only the patient will do well. Many times, if, for example, if you have not justified by taking out the complete mesh, complete sutures, complete tacks, complete dead tissue, then the chances of discharging sinus are very, very high. And again, as Dr. Jignesh had beautifully summed up yesterday, that surgeon should have a good threshold of using the laparoscope, yes, but one should make a habit to go to the micro lab also and send these kind of meshes for microscopic examination, so that one is able to see whether we have sent the vas also for biopsy or the vessels also for the biopsy. And third is that whether this is having tubercular or atypical mycobacteria or not. If, for example, if we take all these precautions and then we do the tissue repair, then only we will be able to make the patient comfortable. Now, this kind of many times, many conferences, workshops, I am asked that what is the role of contralateral prophylactic hernia repair? And we strongly believe that we do not do it. If the patient is asymptomatic on the contralateral side, we never do it. This was a patient who had the right-sided inguinal hernia, but the contralateral hernia repair had also been done. And then, as luck would have it, the patient had infection and he started having discharging sinuses. The surgeon explanted those meshes. So first, can you imagine, he went to the same team and they explanted only one side mesh, that the left side mesh, because the discharging sinus was on the left side. But later on, again, after subsiding the antibiotics, the patient again has started having discharging sinus. Then they took out another mesh. And after that, the gift of ventral hernia was given to him. That this is you can appreciate that patient has had only right-sided inguinal hernia, but left side was also repaired. And then after that, this ventral hernia has been gifted to him because of the explantation of right mesh, left mesh, and then the ventral hernia. And then when we got the CT scan done, there was a collection. This was a collection, and this was the ventral hernia as well as the inguinal hernia. And then we took a decision of placing in a biological mesh. Again, we did the diagnostic laparoscopy. And on diagnostic laparoscopy, why do we do the diagnostic laparoscopy? Because we want to be very sure that yes, the intestines are having any communication or not. CT scan may have missed it, one. Second thing is that whether we will be able to continue with the laparoscopy or not. Or third aspect is the site and size of the incision which we are going to place onto the anterior abdominal wall. In this situation, you can appreciate that we have been able to go ahead with the laparoscopic method, and then one could see the defect also, the inguinal defect on the left side which had been created or which was iatrogenic. And then there was a collection. So as we took the collection, because it was a contaminated kind of environment, then we placed in a biological mesh. At that time, this was a video, slightly old video. At that time, we did not have the biological mesh of a large size. So we had to place 2 biological meshes, and the patient had ultimately been cured of both inguinal as well as the ventral hernia which had been gifted. So what I mean to say, in such kind of dirty wounds or contaminated wounds, one should not place in a synthetic mesh. One should definitely place in the biological meshes. And in this situation, we had to place in 2 meshes of biological, and then ultimately patient did well, and the patient is still not having any recurrence. So what is the surgical site infection? Surgical site infection can be superficial SSI or deep incisional SSI or organ space. If for example, if it comes within 30 days of the procedure, definitely there is a role of antibiotics. But if there is a deep incisional super surgical site infection, then the role of debridement is there. But again and again, our thinking is that we should carry on harping on explantation of the mesh. It is all about finding the calm in the chaos. Such kind of situations in which the mesh infection has been there are many risk factors. So one has to control maybe diabetes, immunosuppression, and so on and so forth, the clinical risk factors. But again, we would love to state here that there are surgeons who will disagree with me and who will question the literature also, that if, for example, if the enterotomy has been done, they still place in a mesh. We are of a strong view that we will not place in a mesh because of the transmigration of the bacteria. We do not think that even if the soilage is not there, even if the seepage of the tissue fluid is not there, still it becomes a contaminated environment and one should not place in a mesh. Similarly, for example, if the bariatric surgery is being done, some people place in a mesh. We do not. Bowel resection has been done in emergency procedures. We will never ever place in a mesh. And in this situation, can you imagine, this was one of the patient, old lady, she had come to us with a obstructed femoral hernia. And when we did, and it was quite old video, that when we were doing the reduction, one could see the lump here. And when we were doing the texts from above and below, we were able to reduce the femoral hernia but on careful watching, we could see that we had caused the iatrogenic perforation. And in this kind of iatrogenic perforation, we would definitely do the suturing by laparoscopic method. No future without suture, as Ashwin Masurkar also repeats our statements. So we placed the suture onto the intestine and did not place in a mesh and came out. And then later on, when the patient obviously had the recurrence of the hernia repair done with the help of mesh later on. But that situation in a contaminated kind of environment, we are not going to place in a mesh. And this is for younger colleagues. I have taken this slide out that the Society of Emergency Surgeries had given a guidelines in 2020, and in this one should definitely go into the details of it. And as all of us know, the CDC also qualifies class 1 to class 2 to 3 and 4 according to the wounds. So if it is a clean wound or clean contaminated wound or contaminated environment or the dirty environment or infected environment, the grading of recommendation will also be different. In the sense, I was much impressed when we call this as grade. That means grading of recommendation, R for recommendation, A for assessment, D for development, and E for evaluation. So the grade 1 is a strong recommendation and grade 2 is a weak suggestion. So in this kind of environment, when there is a contaminated wound, when maybe one should do the laparoscopy or one should do the open method, when should use the biological mesh or not, or whether the patient is unstable in septic shock patients, whether one should do the laparoscopy or straight away going for open surgery. So it all depends on the recommendation and the experience which you are having, for example, in managing such kind of situations. But again and again, as we mentioned, that we believe that yes, there is a role of diagnostic laparoscopy, but even if diagnostic laparoscopy has been done, if it is a clean kind of environment, yes, one can place in a synthetic mesh. CDC class 2 also synthetic mesh. In class 3, that means clean contaminated environment, primary repair is the only repair which has to be done. And class 4 is a query biological mesh, as I mentioned. So these kind of situations, if the patient is unstable and is having complication, the ego should not be lost and one should not offer them the laparoscopic surgery. One should go in for open straight away. And depending on what class CDC, the antimicrobial treatment is there. And last few minutes only on the pain, the persistent pain, groin pain, which persists after laparoscopic hernia repair. And believe me, in the initial phase, maybe 1 week, 3 weeks, 6 weeks, 8 weeks, if many patients can complain of pain, but if the pain is persisting after 8 weeks, that means either it is a neuropathic kind of pain or neuralgia, or it is a non-neuropathic. So if it is a non-neuropathic, for example, it is because of the recurrent hernias, because of the mesh infection or displacement, or because of the fluid collection. And I have seen at least 4 cases of osteitis pubis done elsewhere by TEP method, that the TAC has been reused and they have been applied onto the mesh, onto the pubic ramus, and that causes a lot of pain. And once we get the MRI or the CT scan done, then definitely these situations are challenging situations. But those patients who are not having any such kind of findings on the CT scan or MRI, definitely we label them as neuropathic neuralgias, and in there initially one should try to give a nerve block. You should definitely request the NSS friend to give a neural block. If the pain relief is there with local anesthesia, nothing like it, then carry on repeating it, and many times they will be okay. But if the nerve block also does not lead to the relief of the pain after some time, there is we had invited in Gangaram Hospital Dr. Parveen Bhatia, and he had a beautiful series of triple neurectomies. Though I have not been able to do any triple neurectomy in any of my patients or any other way around, but in triple neurectomies, we had seen his videos dissecting out the ilioinguinal, iliohypogastric, and genitofemoral nerves. He had shown the open surgeries, but definitely I know that people have been doing by laparoscopic method also. One should definitely map the inguinal region and the leg region, so that we know that what kind of nerve has been applied. And I think the last slide which I would love to present is that in this presentation, I have not been able to do risk reduction for all kind of challenges, but we strongly believe that if we give a lot of importance of learning the anatomy well and then practicing it, the chances are that we will definitely reduce the risk as much as possible. We should have a low threshold of getting these CT scan done. Many times, many surgeons I have seen, they carry on they are on a denial mode that no, my patient cannot have seromas, my patient cannot have any challenge or mesh infolding. But I think if one goes in for CT abdomen, definitely one can pick up those complications faster. Again, one should have a low threshold of diagnostic laparoscopy. And then if one is going in for emergency situations, definitely emergency surgery, whether one is going for laparoscopy or for open, it carries a high morbidity and mortality. So one has to optimize the patient, but act fast also in strangulations. And whether diversion has to be done or not, it all depends on your clinical acumen. And then diagnose and treat strangulated hernias properly. But again and again, do not, please, for God's sake, do not place any mesh, any synthetic mesh in those kind of situations in which the infection is there, or strangulation is there, or toxic fluid is there. Even if the bowel loop is viable, one should refrain from placing the mesh. And in conclusion, Dr. Beju and Dr. Sudhir, I must say, practice till it hurts. Keep practicing till it does not hurt. And I think we should carry on unlearning, learning, and relearning. Any questions, I am more than happy to answer. Thank you very much. Thanks a lot. God bless you all.
Thank you, Dr. Parveen.
Details so that the viewers or the participants can avoid each and every caveat and avoid complications in each and every step. That was so beautiful narration of the risk reduction in hernia surgery.
Dr. Sudhir, just before you start, I always say that God lies in details. Devil also lies in details.
Yeah, true. Your one-liners are superb. No doubt regarding that. Fantastic. Yeah.
That's why I said he's a philosopher.
Yeah, true. So we'll go to chat box and we will.
Can you open the chat box? And before that, I have one.
If anybody can ask any question, you can unmute and ask question. But before that, Bhatia, I have to ask you a couple of doubts. You were saying that around some 28% to 30% of the people will have a hernia on the other side also. So in that case, why don't you do bilateral mesh repair? Because many of these patients will have some impulse on cuff on the other side. And if they come with another hernia on the other side, we know doing another laparoscopic surgery would be possible, tap, but it's a bit difficult to do that. And there can be a bladder injury or issues and all with that also. So if the chance of or the existence of the hernia on the other side is so high, why in the primary instance itself, why don't you put one mesh on the other side itself? I have seen that the complication had been there. One patient had a ventral hernia repair also need to be done and all, but that's very, very rare.
No, but first the practical answer, and second is the literature support. The practical answer is that you are overdoing in around 72% of the cases, in which the patient will not develop the hernia and patient does not have the hernia, but still you are doing it. So that will be overkill. One. Second thing is that the literature also, after, as I mentioned, that hernia guidelines, hernia search, and all these groups have analyzed in detail all the surgeons' views, and ultimately they have realized that their contralateral hernia repair prophylactically should never be done. If one starts going in, and practical answer is that if one starts going in for prophylactic repair, then one should do the appendicectomy also along with, cholecystectomy also along with, and so many things can be done. So our thinking is that yes, if the patient has presented with one-sided hernia, you should examine in detail clinically. If the patient has only one-sided hernia, do it. But if the patient also has a doubt in the preoperative clinical room, and you also have a doubt after making him stand that yes, patient is developing the cuff reflux on the other side, definitely I would love that we go in for TAPP, see for ourselves whether hernia is there or not. If the hernia is there, then repair it. If the hernia is not there, please do not.
The point is well clear, Dr. Bhatia, because I was thinking that whether dissecting on the contralateral side to do the hernia on one side would produce some weakness on the other side, or would develop more of a chance of a recurrence on the other side.
Sure.
Because you are anyway dissecting that area, would it weaken the groin on the other side and will produce it? Anyway, the answer is very clear in that the literature support is well.
Yeah, at this point, actually, Jignesh wanted to comment something about it.
Yeah,
Jignesh.
Sir, I think this was a wonderful presentation. What I feel is, in addition to what we have described, the surgeon being the most important risk factor, I have found myself, when I started off, spending time in a cadaveric dissection lab, if you have an access to it, learning the anatomy. And second is virtual immersion by observing state-of-the-art videos of about 8 to 10 faculties on a regular basis will make your anatomy absolutely clear and absolutely fine. I usually divide the risk reduction strategy into pre-op, operative, and post-operatively. You have covered up intraoperatively very well. Just one point is about the tacking of the mesh on the lateral aspect. One should always avoid not to go about 1.5 to 2 centimeters medial to ASIS, because this is where the ilioinguinal and iliohypogastric nerves, they enter into the groin. And sometimes you wonder that I have put in a tack and why the patient has got pain. It is because of the tacking over there.
Sure.
Second thing is, I always keep the landmark, the Lakshman Rekha, the inferior epigastric artery. The moment I see any bleeding anywhere, the first thing is go and clip the artery proximally lower down, because this is the only blood vessel in the body where the arterial blood is going towards the heart. The rest of the blood vessels always go away from there. So I think that is one risk reduction strategy which you can probably master. And the post-operatively risk reduction strategies, because the surgeon doesn't want a recurrence. All of us tell our patients to get back to work very fast, smooth, but the science very clearly says that the integration of the mesh, 80% of that happens in the first 12 weeks. So don't allow your patients to jump around for the first 12 weeks that you can go and play squash and badminton and everything. They take liberty. 12 weeks is the time when you have 80% of the integration. After 12 weeks, they can gradually start with their exercises. You are fine, and your mesh probably is going to get integrated well. The chances of it getting flipped or turned around or bent or anything, everything will be avoided. So this is just 2-3 things which I thought we should add for the benefit of the audience. Thank you, sir. Excellent presentation. Excellent.
Thank you, Jignesh. But I would definitely agree on that one should never ever tag below the level of iliopubic tract, and one should not tag with lot of force from within and from outside, and one can injure the ilioinguinal and iliohypogastric nerve just close to the anterior superior iliac spine. One. But I would not tend to agree to your physical activity in the post-operative period. Most of the times, if you also know, as a surgeon is the most important prognostic factor, if you have done coverage of the direct, indirect, femoral, obturator hernias by a overlap of 4 centimeters at least, even if the patient starts, I am not saying that patient should start the weightlifting tomorrow, but definitely one should go on and carry on exercising, not strenuously, but because if we tell them that you cannot climb down the stairs, climb up the stairs, or you cannot walk, you cannot drive, then the whole advantage of minimal access surgery is gone, and most of these patients will carry on sticking onto the bed. So that is I would say one has to strike a balance.
Yes, sir. So my comment is only regarding the strenuous exercises. I agree with you. Routine activities I allow all the time, but when they ask me, should I go to the gym, should I lift weight, should I play squash, I say yes, this is the time you have to wait. But the routine things, I agree with you. Absolutely correct, sir.
Sure. Anyway, that's a point well taken. One more thing which I would say, Dr. Parveen, is you had to see the groin the next day, because many times the recurrence happen on the table itself. Because when you release the pneumoperitoneum after a TEP, the mesh also might get lifted up, and the sac will come beneath the mesh, and there will be a recurrence. So the second or third day, or second day, if the patient is discharged the next day, you ask them to cuff and see whether it's a recurrence of the hernia. There could be one. But don't confuse it with some seroma there. There would be a seroma, and you can appreciate an impulse on cuff. May not be a hernia, but a hernia recurrence on table can happen. And I would say that that's, if you are not going to TAC, that's one of the commonest cause of a hernia recurrence.
Wonderful. Sudhir, I must tell you a small story. When way back in 94, 95, when we started our laparoscopic hernia repair, in the initial phase only, one of the patient was done in Delhi only, but some other surgeon had done it. Can you imagine that day 2 he presented to us and I could feel the mesh in the scrotum.
Yeah.
And then I phoned that surgeon and he says that yes, he is not in a habit of fixing. At that time, you would remember that the trackers were not available. The hernia stapler was there, but he was not fixing it. So that has made us very clear that we always fix the mesh. We do not want to feel the mesh lying in the scrotum.
Wonderful, very clear. So there are some questions in the chat box.
Sure.
Actually, we'll go one by one.
I think
relevant questions only we will go through. Yeah, you guys say something, Jignesh? Yeah.
Dr. Sudhir, I always train and I myself wait till the patient is completely extubated, because majority of the times it is during the extubation when the patient starts rigorously moving and coughing around. So I always, tend to take a little bit of precautions. And the second thing is, as sir mentioned, we always do a desufflation completely. Then I wait for 10 minutes and I try to, see all the air pockets, everything is out. I re-insufflate after about 5 to 10 minutes and see the position of the mesh. So Dr. Brian Jacob from United States has propagated this technique of desufflation, insufflation test, so that on table you can know whether your mesh is curling or it is going around or it is in the wrong place, so that you are sure that the patient doesn't have a problem. And wait till the extubation. Surgeon should not rush for his cup of coffee immediately. He should probably wait there and then only go back to his coffee room.
Another point which I would add on here is that many times, many surgeons I have seen, they apply lot of pressure from outside, lot of maybe dynaplast or micropore and dressing and whatnot. I do not believe on that. And again, I maintain that surgeon is the best clotting factor also. That if we control the bleeding, if we are not leaving lot of blood inside, then obviously the chances of seroma formation is reduced. So if you apply a lot of external pressure from outside in the post-op period, it is not going to work.
Yes.
Okay. So we'll go through the chat box now. There are some.
Sure, please go ahead.
Please.
Yeah. There is one question. Actually, this has been raised in many of the conferences also. When you do a TEP, can't we raise the flap as a single flap rather than going bilaterally to two flaps? This is asked by Hadil Ahelia. So I think he must be a foreigner. He was asking whether we can raise the flap doing a tap, I presume, as a single incision.
Yes, very good question. I can understand that when we started our PAPP, I learned it from Chris Royston. At that time, there was something called as bikini repair was there. Bikini repair was that once you make a incision, for example, on the right side, the peritoneum is dissected, and then the same incision is continued, and then you do not cut the area which is in between the two medial umbilical ligaments, and then you carry on going behind and then place in a mesh. But believe me, this dissection was okay. Dissection was good, but to put in a large size mesh, that means 28 or 30 by 12 centimeters, one mesh was a challenging situation. So if we are going to place in two meshes, 15 by 12, 15 by 12, so why not give a two incisions and leave the peritoneum in the middle part in between these two medial umbilical ligaments, so you do not injure the bladder also. Place in two meshes, overlap them, and then suture the peritoneum. It does not take much time. So that is the helpful.
True. And there is one more question about this. You were mentioning in between about 17 into 12 centimeter mesh. So there were a couple of questions on that. But I would say the thing is that actually many people would require different size of mesh. Some people will be very small patients. Their infraumbilical area would be very small, and their body span also will be very, very small. In such patients, if you go for a 15 to 12 centimeter mesh, you might find it difficult to deploy the mesh there because it might get folded in the upper part of the, when you deploy it. So you may need to trim it a bit more in a small patient, a small build patient, or the infraumbilical area is small and the span of the abdomen also is less. So
our thought process is that if you are finding challenging, if you are finding it difficult to place in a 15 by 12 size mesh, that means you should rethink that your dissection is incomplete.
Okay.
Our thinking is that if you have made a good dissection, then you should be comfortably be able to place 15 by 12, even if the patient is of a short stature. But regarding the question on 17 by 12 centimeters, I would not routinely advocate that one should use the 17 by 12. Only thing is that, for example, if the indirect defect is more than 4 centimeter, direct defect is also more than 4 centimeter, 5 centimeter, then you may not be able to give a overlap of 4 centimeters all around. And that is the reason that patient will have recurrence. And as I showed you, that large inguinoscrotal hernias can have a higher recurrence rate. In those situations, one should be ready to cut the previous maybe 25 by 20 mesh or 30 by 30 mesh and then use that 17 by 12, so that ultimately it is a one-time affair for the patient. It is not a recurrent surgeries for the hernia repair.
That's okay. But will you get this 15 to 12 into 17 size mesh, or you trim it from a 30 into?
No, it is not. It is not commercially made. Commercially made, all of us know that from different companies is of the order of 15 by 15.
Bigger mesh.
15 by 15. So one has to cut the bigger mesh.
Yeah. So there is one more question. Actually, for a large irreducible indirect inguinal hernia. Now, this is about putting a drain. So what is your take on putting a drain, or else, for that matter, if the patient is on antiplatelets, so you want to start the so I would say there are two types of hernia. Some hernias are red hernia and some are white hernia. In white hernia, every plane is so clean, there is not a drop of blood, and the other hernia is red hernia, everything is red. So at least in red hernia, would you consider putting a drain for a couple of days? Or in no case, or if the patient has been on antiplatelets, would you consider putting a drain for a few hours seroma?
Sure. In my personal thoughts and then the literature support. Personal thoughts are that we have never ever placed a drain because I am afraid of introducing the infection close to the mesh. And I will try my best to clot or to fulgurate or take care of the bleeding to the maximum. But there is situation in which, for example, we are doing with a large inguinoscrotal hernia repair, right? And if you have to give a scrotal incision for taking the omentum out, so for those kind of situations, obviously the patient may have a scrotal hematoma or seroma later on. So one can place in a scrotal drain, but again with the rider that infection should be avoided at all the cost. I am not placing in a routine TAPP or TEP drain, but in a large inguinoscrotal hernias with maybe omentum incision has been given on the scrotum to take out the omentum, then I will definitely love to place in a drain. And literature also says the chances of infection, the surgical site infections, superficial as well as deep, are increased if we place in a drain.
Okay. We do put drains if the dissection is a bit woozy, or if the patient has been on antiplatelets. We put drains, at least one, maybe 16 French drain through the 5 mm port, and would take it on the second or third day. And the infection also, so far, touch wood, we never had an infection from my patient. Anyway, that's another thing. Now, one more question. I don't think we need to discuss about that. During a lap appendicectomy, can we do a lap appendectomy and hernia together? I think you have already answered that. There's no point, we can't do a appendicectomy.
I would, as I mentioned, that even if, for example, resection anastomosis has been done, appendicectomy, cholecystectomy, I know many surgeons combine this, the cholecystectomy with laparoscopic hernia. I am very clear in my mind, it is just like rabies. One should treat it as a rabies. Rabies, even if you get rabies, it is lethal. Same way, even if one mesh gets infected, it will, whole of the country will know Dr. Sudhir or Dr. Bhatia has put in a mesh and it is infected because the gallbladder was infected and it has caused the infection in the mesh. So at least I am very clear. And most of the times, if you have a good pre-operative counseling with the patient, that today I am going to do only cholecystectomy or only hernia, and once you are settled, maybe after a few days, one can choose and one can do the other. Patients agree. Patients agree.
Separate session. Patient will be happy in that. Yeah, we can avoid the risk of infection. That's the most important thing, definitely. Now there is one more question, which they were saying that you go for recurrent hernia repair, and you see that it had been on the peritoneum is so densely adherent to the previous mesh, but you can see a defect as you have been showing. So can you put an IPO mesh over there and suture it around? I think you answered.
I have shown that one of the videos. One of the videos in which we were not able, and then because if you are not able to cover the proline mesh through and through, that means the chances of adhesion formation will increase. So in those kind of situations, one should take a decision that we are going to do a totally trans-abdominal extra-peritoneal as well as peritoneal closure, so that ultimately the mesh is not having adhesions.
Yeah. Yes. So what about using tackers with the biological mesh? In that case of mesh extraction post sinus formation, wouldn't this will be a nidus of infection? They were asking tackers with biological mesh, would it be a nidus of infection?
No,
biological mesh.
But what is the indication of using a biological mesh? Indication of using a biological mesh is a dirty wound or a clean contaminated wound. So in that kind of situation, yes, one can put in a tack, but you are absolutely right. It can be a source of infection. And if for example, I have never had the occasion to remove the biological mesh because it is the remodeling of the tissues which occurs with the biological mesh. But it can become challenging. It can become a nidus for infection. But in those situations in which we had done the placement of the biological meshes, we tagged it with the metallic ones, but we did not have to remove it.
Dr. Hadil is from Afghanistan. She can unmute if she wanted to clarify something.
Sure. From Afghanistan.
Yeah.
I think she's from Baghdad, and she's a lady surgeon, probably a senior surgeon from Baghdad.
Right. Baghdad. Okay, you can carry on, Dr. Sudhir.
Yes. So there was one question to me, how you choose your case for a single port hernia. So initially, I can do only direct hernia, surely only direct hernia. That's actually when you put your scope, you know whether it's a direct hernia or indirect hernia. So pre-operatively, knowing direct or indirect wouldn't matter much, because on table, if you see it's a direct hernia, then only you can do a single port repair, not for an indirect hernia. And another thing is not a big hernia. It should not be that big. You might struggle a bit. So a moderate size, a small size hernia, we can try with a nephroscope. Try dissect initially with the tenemum telescope itself, then later on convert it to a nephroscope and try to do that.
Do you tell the patient that you are going to do single incision or multiple incision pre-operatively?
I tell them all these patients. I tell them that actually I usually do 2-port, only 1 port, but this is case actually I can do it with single port if you are okay with it. Many of them say yes, okay, then I will do that. If they ask me well, what's the rate of recurrence, they never ask me, but if they ask me, I will say that it's a new procedure, we don't know. I also have done a few cases, we don't know if there is a hernia.
They will ask about the surgeon fee? No.
Huh?
If you are using multiple ports, then you are asking for lesser amount or more amount.
Dr. Sudhir, just one technical question. How do you sterilize your nephroscope when you're using it for the single incision?
The usual, we do the ETO, everything we do ETO. And here also, I think either you can go for a flash, you can use your plasma sterilization, that also we use. or our ETO thing we use.
Yeah, because
One of the
it's a fairly bulky, long instrument, and usually
No.
in a flash sterilizer, the space it doesn't accommodate for more than about a feet
not
of
a long
the length of the thing. So
Yeah, it's
maybe
not
I was
that
just
long.
thinking from the technical one. Okay.
It's not that long. Maybe it has one more arm. So it's
Okay.
a bit of square thing. It's not that long.
Maybe it's little wide. It's little wide, I think, probably.
But I would say
Dinesh,
that actually,
most of the times we in Gangaram Hospital, the steroid is being used for nephroscope, and one can easily use that.
Yeah.
and I think the nephrologist or the urologist no more use the nephroscope. They have so many other gadgets to do that. This nephroscope is for us to use for.
You will easily get it from the other theater.
Yeah. Good.
But again,
So-
the caution is that he should not use the nephroscope which has been used by the urologist, or it has been in the Sidex, and then use it for hernia repairs. No, one should not.
Absolutely.
Now, the thing is that
Absolutely.
actually, I would proudly say, touch wood, we never had a infection or inguinal hernia infection. We have treated many of infections, as Dr. Bhatia initially was saying, from outside, but maybe patients are not coming to us, but no infection so far. I think the reason for that would be mainly the thing is that we try to pause this as the first case, first of all, in the theater. Yeah, and one more thing is that we open the mesh only when it is needed. Don't keep the mesh open initially itself.
Sure.
So when you dissect completely, everything is ready, then only you open the mesh.
We should
So-
always treat the mesh as an implant, as if it is a orthopedic implant or a cardiac implant. So give a lot of respect to the implant, and then only infection will not occur.
Correct.
Sudhir, you
Then
can take the other questions.
Yeah, then this question also, I think you have answered. Is it mandatory to tack the mesh? Dr. Bhatia has said that if it's more than 3 centimeter, you have to tack the mesh. So,
We always fix it.
yeah, you fix it.
Dr. Bhatia can also see the screen, that chat box. You can also answer.
Yeah, but I have seen that so many questions have been asked on the chat.
you are not able to concentrate.
So I
Okay, then Sudhir will do the job.
No, I carry on seeing the list on my right side. So many
Oh.
questions have been asked. So
And
it is your popularity.
also there.
It is your popularity, Beju.
Yeah. And to identify questions is difficult. There are a lot of comments, there are a lot of compliments in this. And to find out the right question is
But
difficult.
it's better, Sudhir, it's better read all the comments there, whether it is a compliment or the other, so that we will not miss anything. Even if it is a compliment, we can read that.
No, many
So
people are saying about Baghdad and from different places.
Then one question is, when we decide to put a mesh and when we decide not to put a mesh. Dr. Bhatia has said that actually every patient we have to put a mesh only if it is contaminated, or in some other emergency cases you may not need to put a mesh. Otherwise, should be mesh. Mesh should be.
Mesh is a must. Mesh is a must, and if one has to do a sutured repair in emergency situations, then definitely mesh may not. But you should always tell the patient that we are going to do the hernia repair later on. At this moment, we were obviously giving the justice to the bowel resection or tackling the emergency.
So this is an
Dr.
interesting question. This is an
Dr.
interesting.
Siddesh,
You are saying something.
Siddesh has congratulated you. Dr. Siddesh is, I think he's from Mysore, our own Siddesh, ASA Siddesh.
Yeah.
Said the clear messages, very practical. Then you can go ahead with George Matthews.
He's a close friend. That is why he again belongs to the Society of Mutual Admirers.
Yeah, true. Sudhir?
Yeah, Dattaram was asking from Hyderabad. How long to wait for a large seroma to resolve spontaneously,
Yeah.
or after a lap hernia repair for inguinal scrotal hernia? Do you aspirate seroma in such cases where it is lasting for many months like that?
Yeah, I would say that there is one situation that as if the patient has a seroma, we always tell them 3 weeks, and then another 3 weeks, and another 3 weeks, and most of the times in 2.4 months the patient gets settled. But in one patient, if he had a large inguinal, the scrotal seroma was there, but we do not advocate or we did not remove the seroma under the ultrasound guidance or in the OPD. We always tell the patient that if, for example, I have to take it out, then I will be doing it in operation theater. And only thing is that yes, we took this range, we took out the serous fluid, but at that time, if it is a large seroma, if you just aspirate the seroma, the chances of reformation is very high. So one has to take out the pseudo sac which builds around the seroma, and then only one will be. And I have done in one situation in which I had to take out the complete pseudo sac as well as the seroma fluid, and then only patient settled.
Yeah, and many times it could be a hematoma also. In a large scrotal hernia, it may not be a seroma per se, it will be a huge hematoma, which may not get resolved. May get calcified, you might need to go for exploration. So about this lap chole and TAP, again Dattaram was asking, TAP and lap chole. Lap chole is even otherwise not a contaminated operation, he said, because the bile is not having much of bacteria always. So if you do a lap chole for maybe a biliary colic, he's not mentioning cholecystitis, would you do a hernia?
I would answer this way, as I mentioned about rabies. Same way, I feel from within that even if one out of 100 patients, even if one patient develops infection, I will not be able to pardon myself. As simple as that. Because ultimately, it is why did the stones form? The bile was infected, the stones formed. And even if the spillage was not there, but still you are using the same instruments. If you are using the same instruments and then you are implanting the mesh, the chances of inoculating the bacteria onto the mesh are higher. And God forbid, if he develops an infection, I know there are surgeons who do, for example, lap chole and then tell and justify within themselves by doing TEP. That DEP, they will be able to go ahead. No, I say no. If you should never ever combine these two, visceral surgery as well as the implant surgery.
The infection in a hernia is one of the most difficult thing that you can tackle. Agree. So about this lateral dissection in TEP. So this has been asked many a times. How much lateral dissection will you do? You can go up to the vertebra. People know whether what the lateral extension that you do in a TEP repair.
Yeah, as I mentioned that laterally we should definitely go, and I request my assistant or assistant nurse to push onto the anterior superior iliac spine. And if I have gone in a horizontal, especially when we have started doing E-TEPs, then we can go quite laterally, quite high up to maybe 2 centimeters anterior superior to anterior superior iliac spine. And then below, one should be able to see the mid-belly of the psoas posteriorly and laterally iliacus muscle, so that ultimately when we are making a marsupial for the mesh to be placed, there should not be infolding or outfolding. So we have to make sure that we remain close to the peritoneum, dissect it as high as possible. But again, the word of caution is that please try not to do the dissection on the nerves. If you do the dissection on the nerves, the chances of causing neuralgia and neuropexia are very, very high. So one should be very careful.
Yeah, true, Dr. Bhatia. But one more thing in that, actually, when you dissect laterally, people say that from the internal ring, you have to cover it for some 3 to 4 centimeter laterally should be covered.
Yeah.
So my point is, what is the point in dissecting the whole of laterally and not covering it with a mesh? So I would say that you have to dissect till your mesh fit there comfortably. No point in maybe dissecting up to the vertebra and keeping it without covered by a mesh.
Sure,
So
not up to the vertebra. Not up to the vertebra. I never mentioned the vertebra. But I definitely love that you should create a space in which the mesh is resting comfortably.
So that was some nice presentation and discussion Dr. Sunil Kumar Patnaik was telling you. Then again, Hadil was saying, may I ask one more question, please? What is the optimum compartment pressure in TEP? What is the optimum compartment pressure in TEP? Maybe he may be asking what is the pneumoperitoneum that you keep.
Yeah, we always work under pressure. What So that what I mean to say that even if we are doing TAPP or even if we are doing TEP, we have a pressure of pneumoperitoneum of 15 millimeters of mercury, and we have realized that if you are keeping a pressure of 15 millimeter of mercury, even in TEP, the space is excellent, and it is all a question of making a space. And if you are able to make a good space for the placement of the mesh, the chances of recurrence are reduced to dark. So 15 millimeters of mercury rather than 10 or 12.
So can I just make a comment on that?
Sure.
I think when we initially start with the dissection in a TEP, I tend to keep a little low pressure because inadvertently, even if you make a small hole in the peritoneum, if you have kept a very high pressure and a high flow, sometimes you can have a very, the pneumoperitoneum very easily, and that can hamper your further dissection. So I tend to keep till I get a little bit good exposure of the medial compartment. And then once I get a exposure of the medial compartment, then I raise it back to 12 to 14 and play around with that. This is what is my personal experience. Thanks.
Okay.
My feeling, the answer to this is, Sudhir,
yes, sir.
If, for example, you are making sure that you are very, very comfortable and seeing the single cell thick peritoneum, and you are intending not to injure the peritoneum, you are just dissecting it, not using lot of energy source, then even if, for example, small rent is there, even if some pneumoperitoneum is there, if you ask the anesthetist friend to put the head low, then you are able to progress. But if, for example, even if after putting the patient on head low 10 degree more, if you are not able to progress, then you can put in a Veris needle in the palmer's point and let it be kept open so that still the space is there. And not many times one will have to abandon the surgery because you are not able to get the space. But still, we are maintaining a pressure of 15 millimeters of mercury.
Creating a pneumoperitoneum initially, then to proceed would be difficult.
No,
but if you have dissected well, and then the pneumoperitoneum, is not a much of an issue. But your first port is going into the pneumo, then actually creating a plane, or your second port is piercing the posterior peritoneum. Then the dissection may be a bit more difficult than after completely dissecting, then keeping creating a pneumoperitoneum. That's what actually I felt.
Yeah, I strongly believe that it is a question of lesson number 1, patience, lesson number 2, patience, lesson number 3, patience.
Yeah. So one more question I want to ask you is, you said that no other surgery, but what about TURP? Prostate surgery with hernia repair?
Never. Because I know I have been doing TUR also. Can you imagine that I was trained by urologist Dr. V.S. Rana in MEMC, but I have still been doing TUR also. But all of us know that transmigration of the infection, transmigration of the fluid can occur after TURP. And even if again one mesh gets infected, we had it. So our answer is loud and clear: tackle one problem at a time. Don't solve the problems which are not there.
Yeah, different concepts. Anyway, one more person actually from Pardeep Arora, Manchester, is congratulating you actually, and Baiju also. Baiju, he was saying that it's wonderful meetings. All the meetings are so wonderful.
Thank you.
And enjoyed the
Yeah. I'm happy that he's also connected.
Yeah. So many years.
More than 100 participants are still there to hear your this thing. Answers.
Not mine, Beju. This is your popularity, not mine. I know when last time also Dr. Shikhande was there, you carried on discussing up to 10:30. So I was also, though it was not my field of working, I don't operate on pancreatic cancer and whatnot, but still I could listen to so many questions, and it is all your popularity, man.
True.
Thank you.
The short span of time itself, this has been well popular. So really, it's attracted a lot of people around the globe. Now, Lakshmi Kant was saying.
If Lakshmi is there, can you unmute Lakshmi? Lakshmi is a friend of mine.
Okay.
Lakshmi?
Hello, sir.
Yeah, Lakshmi,
you had asked something. You can directly ask.
Put your video also on.
Okay. So I was just asking, see, for so many years, most of the hernias we have been able to manage TEP or TAPP. And this E-TEP concept, because I was thinking too much of discussion, too much of trauma, is it really necessary? Because I was feeling it was overkill.
Right, good question.
So I just wanted to know, with experience, I've been operating for the past 25 years.
Yes, good question. But answer is that please do not think that you are overkilling it. Please, because I must confess here that all said and done, even if you want to be a learner, if for example, if you are doing a bilateral hernia, we started with the E-TEP, and then we realized that if you have seen the artist, what he does is that when he draws a painting, and then if he has to assess that whether he has done a good painting or not, he goes behind and enhances his view, and then he's able to do it. Same way, when we started doing E-TEPs by putting the trocar higher up on the left side, we could see the anatomy so beautifully. Dissection was definitely more as compared to as we were making when we were making a umbilical or sub-umbilical incisions. So it has added to the armamentarium. Now we love to do only E-TEPs, not even that. And then second answer is that ultimately we are dealing with complex hernias. And if we have to be well versed with all the planes, crossovers and the AWR, then this is the right strategy that one should carry on mastering onto the inguinal hernias, as was described in the literature also. First, E-TEP was described for inguinal hernias, and then later on extended to ventral hernias. So one should go on learning. Once you have done good number of TEP, good number of TAPP, start doing E-TEP under visual with OptiView, and then you will realize that so much of space has been created, and then start doing AWR, and you will be definitely more comfortable.
Thank you. Thank you.
Yeah. So that, someone else also was asking the same question. Dattaram was again asking the same question. You have answered that. Yeah. Now,
Dattaram also is from the same place Lakshmi belonging to, right. Hyderabad.
Hyderabad.
Yeah, true. So, hi Lakshmi.
Hi.
So one more question is, what is the inferior extent of lowering the peritoneum? You said that, no? How much of the peritoneum? Inferior extent of lowering the peritoneum.
Yeah. So basically I showed in the video also that we should aim that the angle of dome is converted into a triangle of dome. That means the vas deferens, the testicular vessels. Once the vas deferens starts turning medially, testicular vessels turn laterally, and this limb of the reflected peritoneum is absolutely horizontal, and laterally we have the mid valley of the psoas. That is our limit. Many times I would say that if, for example, there is a leaf of peritoneum which is attached still onto in the triangle of doom, that can cause recurrence. So one should make sure that whole of the peritoneum is dissected off and it becomes horizontal. That is the crux of an excellent hernia repair.
Well said. So inferior epigastric artery, one Galaxy Note 9, the name is not very clear here. The inferior epigastric artery bleeding. So if it's something like that, you clip it or you go with a harmonic scalpel and you just cut it. If the inferior epigastric artery for some reason.
Sure. Or a transfacial suture.
Yeah. Basically, as Dr. Jagnesh also mentioned and Dr. Beju is also mentioning, it can bleed like hell. It can even the corona mortis is a different entity that bleeds like hell, but inferior epigastric also can spoil the field very fast. So if you are able to do the suturing, and that to a transfacial suture, for example, needle and suture, nothing like it. Because if you start using the monopolar, or then the vessel will retract down and you may injure the external iliac artery also. So we should be very, very careful that we are tackling it with the suture.
With suture, you always suture. Okay. And the corona mortis bleeding from the accessory obturator artery, corona mortis, that area if you bleed. So how do you tackle it?
Yeah, I had one experience of injuring the corona mortis, and it was an initial phase, 95, I remember that. that bleeding would not stop. We started, first we put in a gauze piece, we waited for 5 minutes, 10 minutes, it will not stop. And then we put in a lot of pressure, it will not stop. Then we, obviously at that time, our anatomy, let's be very honest about it, the anatomy was also not very clear that it is ultimately, it is an anastomosis between the external iliac artery and internal iliac artery, and the obturator vessel is giving rise to the pubic branches. But now we realize it, and at that time, what we did was that we put in a hernia tacker. You would remember that OMS, EMS and OMS hernia tags were coming at that time. So we had to apply on both the sides of the bleeder, and then only we were able to control it. So in this situation, it is better not to rub onto the corona mortis, not to rub onto the pubic ramus, never cause this bleeding. As I mentioned, that if this bleeding occurs, surgeon starts thinking, why was he born? So much of bleeding can occur.
So it was George Matthew was asking that question, how to tackle the corona mortis bleed. Siddesh was saying that it's clear message that you have given to them. Very practical. Congratulations, Dr. Bhatia.
Dr. Sudesh, if he is available here, can you unmute, please?
Yeah, sure.
Yeah.
Sir?
Sir, what I like most about Dr.
you have to
Parveen is
switch
that
on
he is
the
very
video.
clear in concepts. Whatever he says, he is very sure of what he is talking.
Thank
Sir,
you.
why can't you show your video also?
Yeah.
I have to see your face.
Yeah.
Yeah. This is Dr. Siddesh from Mysore. Actually, he was heading the unit at JJ Hospital in Mysore. Now in a private hospital heading, he is the one who doing laparoscopy as well as ERCPs.
Suresh, how are you? Good to see you. Good to see you. And I must thank you for appreciation. And definitely it comes from within. Let's be very honest about it. That if it is coming from within, it will be clear. And most of the times we should not try to unnecessarily overload the information.
Thank you. Dr. Sudhir, please.
Yeah, it's almost over. Now, Shyam Sundar has asked so many questions. Shyam Sundar, are you there? Shyam Sundar, you can
Sundar
unmute,
is
show
there with
yourself.
me. Actually, he is my colleague.
Asking a lot of questions. Many of them were answered. Most of them were answered.
Right.
Yeah. Okay, so that's it.
Sudhir, I have one question. I'm Dr. Abhay.
Abhay, you are also there?
Dr. Abhay
How
Davi.
can- No.
Before that, sir, before that, I must introduce you. Dr. Abhay Davi is there, who is the president-elect.
I have one question for Parveen Bhatia.
Sure.
I love so much for his, every morning quotes. So Lord Moynihan said, have a big incision. We have boiled down to laparoscopic surgery. Now you are saying, I'm going far away and I want a better exposure. So can you give me a quote which will say that we are still learning in hernia surgery because you want better exposure. So by going far away, you are having a better exposure. And what are the things to come in future?
Wonderfully planned, Abhay, but I must ask you a question, that how come that you were sticking on to us for last 1.5 hours or maybe 2 hours? You have so many responsibilities. I know that.
I got to keep a watch on Dr. Parveen Bhatia all the time.
I know. Thank you. But again,
he is the president-elect of ASA and he was the president of Hamasi also. So to the delegates.
No. One minute. Correct yourself. What I'm saying is, it has been a wonderful discussion. Let me tell you, and I got to credit Parveen and Sudhir, who have been really good in academics. There is no doubt about it. And Parveen has been trying to, fight corona on one side. He puts up videos about how to get out of this corona fear, etc., as well as having academic activities with other people. Real due credit to him, because it's not very easy, especially with the history of Gangaram also being attacked for some things, and he's the director there. Yes. So kudos to Parveen, my hats off to you. I just came in to just not show my presence, but E-TEP, I don't do it. TP, I refrain from doing it. but still you were talking about wide exposure. So I just went back into the history, like to find out, Lord Mohinyan's this get a bigger incision, etc., etc.
Sure.
So I just thought I will just pinch you a little bit.
Sure,
I have
you are always
that.
welcome. You know that you are always welcome. But again, I strongly feel now that yes, all of us are learners, and we should carry on learning. We had challenges when we were doing a TEP for those kind of patients whose span of umbilico-pubic symphysis distance was less. In those situations, definitely I had the challenge. Let's be very honest about it. And I used to feel that if possible, if we get an access from a distance, why not? And then we'll be able to do the justice. But after doing in those patients, small span patients, umbilico-pubic symphysis distance, then we extended on to every patient, now young patient also. And if we see from a distance, we draw a line from the umbilicus, from the subcostal region, and then just in middle point of that, we give an incision, and it is medial to the semilunaris line. And when I start appreciating layer by layer with the help of OptiView, that means skin, subcutaneous tissue, the anterior rectus sheath, the muscle, and then we are able to glide over the posterior rectus sheath, I think this is a wonderful orgasmic feeling, I would say that.
I think that's the crux of the situation, that when you go a little away, you are always in the correct plane where you are not when you go around the umbilicus. And I remember Dr. Bhatia telling me that you got to dip your cannula when you take a subumbilical incision. And if that dip is not proper, you are in a wrong plane.
Absolutely.
And that's why I appreciate this forum for bringing to light all those people who are attending, that probably E-TEP is a better one, faster to learn because you are in the correct plane.
Sure.
Thank you, Dr. Bhatia.
Thank you.
I think we should take this from gynecologists who have now gone up from umbilical port to supraumbilical port to do their surgeries also, to get the ergonomics right.
Absolutely.
So, yeah, Sudhir and Parveen, my heartiest congratulations to you.
Thank you.
I'm not recognizing many other people out here, but thank you so much and welcome. I will be happy to contribute any way I can, even as a delegate, no problem.
Sure.
Thank you so much.
Thank you very much, Albay. We know that you have always been belonging to a society of mutual admirers.
Thank you, sir. Thank you so
God
much.
bless you. God bless you.
So, is there any other question from the audience? We have again still 81 people in the discussion. So, if you want to ask,
anybody who wanted to ask questions can raise their hand. Dr. Sunil from Cosmo, Trivandrum.
Yeah, please go ahead, madam.
Hi, yes, sir.
Madam should be given a priority. Yes, go ahead.
Thank you so much, sir.
Yeah.
I am Dr. Anjali from Nanded, sir. Just as you were admiring regarding the E-TEP procedure. So my question is, sir, in routine E-TEP, what is your upper limit of the mesh extent? And in the E-TEP, suppose we are operating TEP. And now with the advent of the E-TEP, what is the uppermost extent of the mesh? Is it altering? And second thing is, by doing E-TEP, also preventing the ventral hernia.
Yeah, good question. Basically, question which I understand is that
if we are preventing ventral hernias also, so why not to apply on both the side 30 by 30 mesh in a continuity, sir?
It will be asking for too much.
Dr. Bhatia, let me intervene here.
Yeah.
She is an excellent surgeon working in a small place in Maharashtra, but is also on the executive of Maharashtra State Chapter.
All right. So
I'm very cautious. A lot of laparoscopic work as well as a social work for people in and around her.
Wonderful. So definitely I will be more cautious in answering. But my answer to this is that you have asked a good question, that if you are doing E-TEP, and then what is the upper limit of the mesh placement? We are not changing the size of the mesh. It is same 15 by 12 which we are using, whether we are doing TEP or E-TEP. Only thing is that, as I mentioned, that in those kind of situations in which the span was less, then the upper margin of the mesh would not lie absolutely straight. It would get curled in, or one could see that it was not a straight space. But once we started doing E-TEP, now we are able to place, and you could see the videos also, we could place the mesh so beautifully, so comfortably. We have not changed the size of the mesh, but we have been able to straighten the mesh in such a manner that the ultimately infra-umbilical level, it reaches infra-umbilical. Second question was that, are you preventing the ventral hernias also? Yes, in those suprapubic region, if the hernia had to occur, then we are preventing it. But if it is in the umbilical region or in the supraumbilical region, no. Then for that, it is the E-TEP, maybe ventral hernia, maybe E-TEP RS, maybe E-TEP TAR, and so on and so forth. But for graduating from E-TEP to E-TEP RS, E-TEP TAR, one should, I think this is a good exercise. Once you have done a good number of EEPs, then start doing E-TEPs. But please do not do it with finger dissection and whatnot and whatnot. Eyes don't lie. Our thinking is that if you are seeing it and layer by layer and then going it and then diving in the anterior to the posterior rectus sheath, that is the plane.
Thank you very much, sir.
Thank you.
It's a very good question. Thank you. I think it has been a good discussion. Thank you, Dr. Bhatia. You have covered very well all the small minutest point to how to prevent a complication or recurrence in inguinal hernia surgery. Fantastic. Thank you very much. Thanks, Baiju. I am back to you.
Thank you very much. But I must tell Dr. Baiju that he eats only compliments. That he is conducting every Sunday evening such kind of shows, and it will become a Senadhipan Baiju TV show, and he eats only the compliments. Wonderful job being done. Please carry on spreading the knowledge. Knowledge shared is knowledge gained, and I am so happy to be part of it. And I must appreciate that many surgeons from abroad as well as in India had joined, and we would love that anything I can do from my side, I'm more than happy to spread that message.
Thank you so much, sir. Thank you so much for your contribution.
Hope we don't lose Dr. Parveen Bhatia.
I know so many meanings he is conveying.
No. I'm conveying. I always convey very straight.
I know that.
He doesn't know double meaning.
I know. No. Abhay has been very close friend, but he always has a habit of pinching, and that gives me a push.
No. Let me tell you.
No, you are muted. No, you are muted.
Unmute, please.
Unmute. Yeah, go ahead, Abhay.
I have been always straight in my life.
Right.
I have placed spade as a spade. And the problem is, whenever I talk, the other person takes it. Now, I can't do anything about it.
It is the problem with the other person.
Expect you to ask me very straight. I'm going to be in a position of power, and I want every person to ask me a question and don't say that I don't know the way you're talking. So, I mean, Baiju, all of you all in important positions, please be with me. That's my appeal.
Sure. We'll always be with you only.
We are
Ashwin,
now, the TAR man.
Thank you.
Ashwin,
Thank you,
the TAR
Sudhir.
person.
Thank you, Baiju. Thank you, Parveen, for an excellent job. Absolutely.
Thank you.
Thank you so much.
Thank you, sir. Thank you for joining.
Thank you. So
Ashwin, you wanted to say something?
Thorough session.
has also joined.
Covered. I've been always here. Just my video was off. Wonderful session and very thorough. And I didn't realize how 2.5 hours just passed by. Fantastic.
Thank you, Ashwin.
Thank you. Ashwin, we need you later for another presentation.
Sure. Always.
No, I had been witness to one of his presentations recently on TAR, and it was a wonderful presentation. Wonderful. I have learned a lot.
He is one of the persons who started AWR in India.
Sure.
Way back, almost 20 years back, is it, Ashwin?
Yeah, something like 16, 17 years ago.
17 years ago.
Yeah.
He's not that old. He's not that old.
He is not that old also.
The problem is we require recognition from outside the country.
I know.
Then only you are recognized. So there's a famous saying that when it starts raining in America, you open the umbrella here.
Yeah.
So his training was in Seattle when he presented, and then when he came back, people started opening eyes. That's the situation that happens, unfortunately, out here.
No, this is with the Nobel Prize winners also. Satyarthi, all of us know that he never got any recognition in India or in Delhi. But when he was given a Nobel Prize, then people started thinking, who is this man?
So I think we should be traveling abroad faster.
I know. God bless.
Yeah.
Anyway.
Thank you.
Thank you all. Thank you, Abed Ali sir. Thank you, Siddhesh sir. Thank you all other participants, Dr. Jignesh, Ashwin, Dr. Parveen Bhatia, the speaker, Dr. Sudhir, the moderator, for all your contributions and participation.